I'd like to turn to our second speaker this morning, and I'm very pleased to be able to have Dr. Chika Onwuamah with us from our Nigerian grouping. And Chika is the Chief Research Scientist and Team Leader in Population Genetics and Cancer Research in the Center for Human Virology and Genetics at the Nigerian Institute of Medical Research. So just to briefly tell you about Chika, he did his PhD in cell biology and genetics, and since 2001 he's worked on helminthic infections, malaria, population genetics, genotoxicity, and HIV drug resistance. Yeah. And then from 2006 to 2017, he coordinated quality control and assurance in Nigeria's first ISO 15189-2012 accredited public laboratory, the Center for Human Virology and Genomics. He then led the center from 2017 to January 2020. So this morning, Chika is going to talk about more on the diagnostic and surveillance side, and we're very interested to hear how this compares in Nigeria with what's been done in the UK. So his title is the Nigerian Institute of Medical Research, COVID-19 Response from Diagnosis to Surveillance. So thank you very much, Chika. Could you share your screen? Thank you.
Okay, so I would say I'm probably going to start a bit from what Professor Altan described as he was ending. There was a lot of synergy that characterized people's response to COVID, and that was what I wanted to share with you, where several colleagues at the Nigerian Institute of Medical Research got together to be able to respond to this thing that was new to everyone. So Nigerian Institute of Medical Research is the apex biomedical research institute in Nigeria, but it dates back as 1920 when it was the West African Council for Medical Research, working mostly on yellow fever. And then it does a lot more research, basic, applied, operational, and how to disseminate it, and working with federal institutions and international institutions to go about research for national health. So just to tell you that it's actually a standalone parastatal. It responds, is under the government through the Federal Ministry of Health, but it's a standalone under the Director General of Nigerian Institute of Medical Research, and it has 5 operational research divisions and 4 support divisions. So most of our activities, we work a lot on virology, diagnostics, as you get to see, some of the genomics, and we have a lot of services, given that most of what we do here, we pioneer some high throughput services, and once people take it up in the country, different labs, we move on to other things. And underpinning all of that is a research activity. And then we have the quality management system to make sure that each of these things is done qualitatively. As it is the center where I work, we have 2 WHO centers for pre-qualification for IVDs and then for HIV-DR. So going into our response to COVID in Lagos, Nigeria, Lagos was the epicenter. So the index case was actually also in Lagos. It happened in Lagos. But before all of this, 2 of our staff spent 3 months at the China CDC in Beijing. There was a program we worked with them on a fellowship program for molecular detection of pathogens. So we visited China CDC. And after that, in January 2020, a colleague came from there. And after we finished talking, we were like, oh, have you started testing for COVID? They said, no, we got our first test from them. So even before the index case, Chinese expatriates returning to Nigeria from their lunar holidays, we were already testing them earlier, and we were able to get some experience ahead of time. And we were able to advise others as the thing came into the country. And we had a new placement of a real-time PCR machine, and that was the very first assay we ran on it. So the index case, as it came in, it was actually tested at another facility, and we got it, I think, the next day or thereabout, and we confirmed it and went ahead to sequence it with Sanger, and we were able to confirm, yes, that this was COVID. Lagos is the epicenter, like I mentioned earlier. About 39% of the whole recorded and confirmed cases in Nigeria happened in Lagos. So because of that, it's a city of about 20 million people. because of that, we had to work with different people and set up a modified drive-through center to offer free testing to the public. And also, based on what we could do then, because at first we only had Sanger sequencing workflow, we developed primers to do whole genome sequencing of SARS-CoV-2, and we published and shared our experience with other people in case those that have just that can still be able to do something. And then we were able to share experience also about the work, the center, because the center, we had to modify it to working with what we had in Nigeria, where we have a lot of people who can work in. And that was a big part of the modification. So just showing you that here in Nigeria, they've had about over 256 confirmed cases, and Lagos had 99 of that. So it's about 39% of the whole case, and the very next state has about a third of what happened in Lagos. But if you look at the numbers tested, about 5 million, Nigeria is a country of about 200 million. So we are still lagging behind in tests, and we are looking forward to do a lot more of that. So in our drive-through, one of the things we did was that we didn't want paper documentation, so that we reduce contact. So most of our things were hosted online. People will fill in the forms if because we were too much of a rush and we couldn't take everyone at the same time. So we had to find a way to break and say, okay, we take this person, we take that person. And then when they move on to fill in the symptoms, everything is done online. As you come into the center, we just confirm the number that we are given, and we make sure that your details are correct. You go in for testing. In about 5-10 minutes, you were out, trying to minimize testing. If you can see from this schematic, if you come in with a car, you can have a pathway you can drive through. At the station 1 and 2, they can confirm simultaneously, 2 different people, your details. And once it's okay online, you move in for sample collection. You don't need to come out of your car and then you drive out. Then we had on the side the pedestrian entrance where they can come in and then go through the same process separately for pedestrians. So that was the big part of it. We modified it for our people. So earlier on also, there was this fears about COVID and malaria. And being in malaria endemic countries, people are wondering, oh, in fact, at some point I heard people saying, are you sure mosquitoes doesn't transmit this? And you know, the earlier, all those unfounded fears about COVID and everything. So we had to kind of allay the fear, did some research and showed them that the patterns were different from malaria transmission patterns. So they are not synergistic in any way, and it's not going to affect anyone. So I allayed a bit of that fear. And then we followed that with 2 other papers describing the clinical and demographic characteristics of COVID patients we saw in Lagos, trying to tell what were the symptoms. We were able to isolate 2 great things. First one was the sore throat and fever. So these are the ones that were very clear in all the patients that we saw here in Lagos. And that was something that we could use as an identifier. And then trying to look at our experience sharing institutionally, because we were able to start earlier, and then many people were calling on us to tell us, oh, how did people do it? How is it going on? And being that we're in the epicenter and we are testing, I think we've done more than 50,000 of the tests in Lagos here. And we were able to walk a lot through the first 2 ways, but we can't go around sharing, telling people how to set up or sending people to an institution to come and tell them, okay, you do this, you do this. So we had to put it together in the paper, sharing all our, how we're able to respond. It went through from development of diagnostics to at a point we are developing a viral transfer medium, because at the peak of the lockdown, nothing was coming in. And if you had anything coming in, the cost of shipment was almost 5-10 times. So we had to start, so those that were doing cell culture earlier, started developing the transfer medium. We went as far as developing our hand sanitizers and all that. And we were able to guide institutions what to do, even the biosafety measures, because for a while, everybody was afraid. We had a biosafety laboratory. We would take in the samples, decontaminate them before we go into the biosafety level 2 for the PCR and all the real-time PCR. But then we could tell people that even if your PCR 2, if you do some things, you can actually do it effectively. We monitored all the people in that response for about 6 weeks. In fact, at some point, most of them were not going home. They were kept in a hotel within the institute. And then when they have to go home, they have to test before they go to their families. And we were able to tell them that all that even got infected at that time were basically those who were at the drive-thru, not in the lab. So if you still use a biosafety level 2 lab, you can still do things very well. So many people were able to start up thereafter and start testing the various states in the country. So we had to mentor people also on quality assurance. given how COVID came in, a lot of people were getting into real-time PCR for the first time. And it was a lot of issues. For instance, people are getting used to the system. There are different types of real-time PCR systems. A lot of them are very free. You can change a few material parameters. Some are a bit locked down, so I can do a bit of IVD kind of thing. And then there was so much turnover in the extraction and real-time PCR kits. It was a nightmare at some point because you could be working with one kit today. By Wednesday, it's finished because of the turnover, and you have to now, we have another new kit. You have to go and read the kit inside, know what to do, what's their cutoff, and all that. So we have to share our experiences because people were asking us, what do we do? How is this kit performing? So at that time, we had 5 that we really worked on and tried to share that experience. And at a point, everybody knew about the MDX gene. There was a time they reduced the cutoff from 39 to 36. And then we were a bit worried what was going to happen. So we looked at that also. Between that 36 and 39, there were a lot of people that were still positive on other assays. And if you look at the picture here of a table, you will see that most of those who were just over the 36 were fully positive and picked by 4 other kits. So these are some of the things we had to share with them and tell each of the labs, as you get this, each of the new assays, set up something quickly and find out what is your cutoff, what will be your threshold. I wasn't surprised when I saw that BGI led to a lot of, what would you call it, false positives in Sweden at the point, because their cutoff of 38, for us here in the lab, we have established that, it's a lot too high. We were cutting off at 35. So if you have 35 and we repeat it, if it's consistent, we give you a positive. If it's not consistent, we say it's a negative. So we had reduced our cutoff to 35, and then we were able to share that experience, and most of the labs could begin to do something before they start using the kits for diagnosis. And we're able to just pass on that experience and mentor some of the labs without actually having to go to their facility. So in trying to live with the health system, as the pandemic matured, some people are still in denial, but we may have to get to a point where we may have to live with it. So other health systems, we are restarting, our HIV programs are restarting, different programs are restarting, and we have to think of how best to go about this. And our government procured the NGS system that will go from sample extraction. We had some automated library prep and all that. So we could do a bit of genomic surveillance for SARS-CoV-2 and all that. And then part of this, people were a bit worried about blood transfusion. So we had to do a bit of research. Yes, we could see some of it in the blood, but the implication for blood transfusion was not that much. It wasn't very high, and we weren't sure what if it could lead to infection. And then one of the greatest things that came out of it was to design a do-it-yourself sample collection kit. At some point, I think during the Delta and also a bit during the Omicron waves, most of our people that were doing the sample collection at the food drive-through center actually got infected. And then we had to now make do with mega staff and trying to make sure everybody was safe. We designed this with a small video. We showed them what to do. So when you come in, we tested that and it really worked comparably well. And we could push that out so that you can actually even still be isolating. You can order a do-it-yourself kit and then send it across to us and you can do the testing. And then as people were resisting the lockdown and different things, that could be something that we applied and we used it several times. I remember in one of the programs we had a workshop, and all the people that came in, it was the do-it-yourself that we used. They just stayed apart. So people were coming over from all over the country. They came for a workshop. Before you entered the system, we did a do-it-yourself. And one of our test kits that we developed that could give results in 30 minutes was an isothermal PCR. I'm going to talk about it a bit further down. We could get the result in 30 minutes, and before we can tell them to meet. And in that period of time, using these two, we were able to discover people that were positive, even though they traveled and came for the meeting, and we had to isolate them before the conference went on. So there was a bit of discrepancy between the do-it-yourself collection and the health workers collected. It was not something to be worried about 6 of them. And then if you look at this, it was more acceptable, the graph on top, it was more acceptable to the young people who are very mobile, and it was an easier way to get them to test. So instead of telling them to come to the center and queue up, or maybe come to the center, they'll be looking they'll be not receptive of that. We could send that kit to them, they sample themselves, and we could test them. They were more receptive to that kit, and we were able to use that and move on. So also going on to the genome surveillance networks. Earlier, we only had Sanger sequencing. In fact, we've been using that same workflow since 2008, and we've done quite a lot of HIV drug resistance testing for clinical purposes, so they can change their drugs and all that. So we had to now collaborate nationally, working with HG, one of the institutions in Nigeria that had already NGS system. And then we're able to pull our samples together, and we're able to do some of the genomic surveillance, telling what is going on, learn from one another, and perform genomic surveillance reliably. And then also within Africa, we were able to collaborate with a lot of people, with Tulio, Professor Tulio Liberio in South Africa and some other networks. And we have published about, okay, one is still in under review, talking about this network in Africa, how we're developing and learning from one another. And then from the Nigerian network, led by the SG team, we were able to come up with something on bioinformatics, trying to explain the origin of the Nigeria-specific variants that have been recorded during this COVID era. So we had another network I went to a bit zeroing on within West Africa. This were a team visiting us from MRC, the Gambia. I don't know, some of us may know Dr. Abdul Sese. He worked in UK before he went back to the MRC, the Gambia. So they came visiting and they were introduced us to the alpha nanopore technology, and it was really faster. I love that part. So the collaboration was spanned across the wet and dry lab. Within 10 days, we had finished the wet lab, the dry lab, a bit of the dry lab, and we had to still go over and have some other trainings in the data analysis. They had a HPC, and they gave us access to their HPC. But when we moved on, we were able now to develop and get the Midnight kit from Nanopore, and we could really use their AP2Me is an online analysis platform to analyze our data. So that's what we're currently doing. We're able to do some retrospective testing, and we are surprised to find out that Omicron was first picked in samples that we saw in August 2001. This is actually something in review right now. And then we got a grant from AHF, AIDS Health Foundation, to do surveillance in travelers, both inbound and outbound, to find out what is going on, to see if we are the one exporting things to the world or it's coming in. And it's been quite helpful to see what is going on. And recently, I think 14th of this June, we were able to detect the first 2 cases of B4 and B5 in Nigeria. And they actually came in from travelers coming into Nigeria. And then within a few weeks, we now got 8 from the community, from 3 people in the community. So it's already spreading, and we had to make up an alert to the government that this has come in and it's in the community already. So they are trying to be, and currently there's an uptick in positive cases in Nigeria, and we hope it doesn't get too high before it's well controlled again. So there's another group we are working with, Professor Gupta's team in Cambridge. He was one of our speakers at our conference, annual conference in November. And then after that, we discussed some other things we could do. So there was something we did earlier. Before the health workers were vaccinated, they were prioritized in Nigeria. Before they were vaccinated, we actually took samples from them to establish baseline, and then they were vaccinated. And before their second doses, we took samples again from some of them, and then they were not vaccinated. So we now look at this, and they also helped us look at the antibody responses in this, doing some neutralization assays and among others. So these samples were taken when Delta was circulating, and we tried to determine the baseline antibodies to SARS-CoV-2 and what were the level of protection. So it's something already in preprint online. We find out that prior to the outbreak, there were a lot of exposure to SARS-CoV-2 among these health workers. We have been responding to COVID since February, March 2020, and then, but against Omicron, these responses actually were low, and we should actually look at boosters. So some of us have already been boosted, and one of them, and we've been boosted, and then we are still looking at how we respond to the various variants of concern as they come up. So a bit on my team, the population genomics and cancer, we do a bit of population genomics and epidemiology, tracking HIV drug resistance, and a few of the things we are looking at now, preeclampsia in pregnant women, something we're looking at, and also work with someone to look at some SNPs affecting endometriosis. And then we are on cancer, we are doing just for now, we look at on genotoxicity of ARVs. And then some of my MSc students are working on mitochondrial defects among people who are on ARVs. And then we are doing quite a lot of surveillance on HPV, DNA testing to see those who have that. And there's a particular group we are working on right now to get those that have cervical cancer, to see what were the strains in them, because we are seeing a lot of other high-risk groups, and we're trying to see, can those other high-risk groups actually lead to cervical cancer? The diagnostics is actually what brought us into this group. So we're developing point-of-care diagnostics. Near point of care, we are using isothermal PCR, not the lamp everybody's used to. We're using recombinase amplification, and it's worked very well at lower temperatures at about 3940. And then I'm going to show you a bit of what we have done thus far with it. So we were able to get some funding from Faith Foundation in Nigeria. That's about, it's about $45,000 to develop a point of care test for SARS-CoV-2 and then demonstrate it. We were able to do that, but we've not been able to move that up since. At the peak of the pandemic, we were testing and we were working up to 11, 12 p.m. every day. So it was so hectic, and we had to develop this so that other people can do the assays on their own in small side hospitals, in the theater before you enter, because there were some people, health facilities, the health care workers were dying because they were overly exposed. So we're able to have this give results in about 36 minutes. Actually, from 5 minutes, you have results, because it was even up to 30 minutes to detect the lower people. And then here you have a lot of what we use. So you can carry it in a small suitcase, and we have the equipment beside a PC, a laptop there, so you can see how small it is. We actually use this workflow so to make the readouts standardized, because instead of using the lateral flow, whether you are subjective, do you have a line or not, we now use the real-time system where you have hex and farm, and then we use that to pick the different things. So we have this, this was just like a titration at different stages. We were able to pick 10 to the power 5, but by the time we linked it up to add a human antigen, because that was supposed to help us check whether the sample was well collected. So if the sample was well collected, the human gene should show, and then we'll know whether you're actually negative or a sample was not well collected and there's nothing in the sample. At current, it's giving about 95% sensitivity, because the real-time, a reverse transcription just only for 6 minutes. So we're just looking for more enzyme that will be more effective at that temperature of 40, and then we're able to bring up the sensitivity. But the specificity is excellent as 100, and it can detect as low as 555 RNA copies per mil. So this is just a bit of how the result looks when it's going on. And we had another one developed earlier than this. That was why we could develop the SARS-CoV-2 fast, where I was thinking of 11 pathogens that cause fever. I had a son who was always having fever, and I tried to think of what we can actually do to develop, to detect what's actually causing the fever. And so we multiplex things to get 10 pathogens involved to give results in 30, 60 minutes, so that if a child comes to the facility, within 1 hour, you will know what to treat the child for, and something that can be scalable in any category of health facility. Just a bit of the results. It's been found to be okay. In fact, it's sensitive. It picks the samples for those who are high, but the few of those who were late, one of the ones highlighted in yellow, it did not pick them. But something interesting I wanted to point out here, out of the 10 pathogens we are looking at, some of the samples I received, when I did part of this working in China CDC, when we spent the time there. So they gave me some samples that was probably Streptococcus. Yes, we got Streptococcus, but they actually had other things. So this could also be something of a game changer for us here, where it's often easier to have co-infections and different infections, multiple infections, and then you'll be wondering why I'm treating for what I'm supposing is the symptoms I'm getting. One is recovering, one is not recovering. We had other people who had 2 infections at the same time. So this is something that's very good when you use syndromic panels. And that's actually one of the things that we are going to do with this group, where we are going to be developing, trying to see if we can make this SARS-CoV-2 assay into a respiratory illness syndromic assay. But more importantly, we propose to do a One Health panel, where we'll select 10 or 11 pathogens that are most likely to jump from animals to human. And then we have that at key areas. Along our country, at some key travel positions, we have people that kill wild animals in the bush, and they come out and sell them to travelers. And at those key positions, we can set up sentinel surveys to be sure among the people who are also processing those wild animals and people who are buying them, to see what is going on at the same time. And then often we have this seasonal cholera outbreaks in Nigeria. We're also thinking of something like that for a gastrointestinal syndromic assay that can just scan through a lot of pathogens and see what's going on. So I believe we will engage more in this area. And I've tried to show a lot of the things in trying to summarize what we've tried to do, so that introducing the institute, and you can also link up with any of our scientists who have been involved in this, right from the hand sanitizers that we were able to locally produce when we couldn't get them or buy them, the viral transport medium, to extraction kits. One of our colleagues earlier had developed the DNA extraction kits. When COVID came in, she managed to develop the RNA kits, and we had to wait a while for some of the inputs to come in from outside the country. And then development and validation of the near point of care assay, which we are pushing forward, that will help us, given our environment. It works in a small mobile battery, and then you can do molecular tests reliably, and then you can get a result. We've been able to also do quite a lot of routine qPCR for SARS-CoV-2, and then routine qPCR, real-time PCR for yellow fever and Lassa fever, which are local issues here we're trying to track and know what we can do. So it's still a work in progress at about 80% sensitivity, because we are still trying to do a lot of sequencing to be able to characterize the viruses and then be able to develop primer that can cover all of them at the same time. So I want to say thank you to Faith Philanthropic Coalition for Against COVID. They really were the only one that came up at that time to help us with that $4,500 to even to come up with the one for SARS-CoV-2. We are still looking up how to take some of these things from products or what we call it, prototypes, to actually things in the market, and we are open to people that can help us do that. I mentioned about 3 different facilities here: Chasby in Lagos State University Hospital, 54 Gene and Biologics Lab. They were in the Nigerian Center for Disease Control. They were the ones that tested all of our prototypes. So all the prototype diagnostics have been producing, they've really been testing them, and it's been they've really been wonderful. We're throwing it to different things and giving us reliable feedback, and then we're able to know how well we are doing. So my team, there are a lot of them. I couldn't really show their pictures because of the slides already too many. Thank you. Some of them are online at this time. And Nigerian Institute of Medical Research, the Director of Nigerian Institute of Medical Research, Professor Babatunde Salako, he has really been wonderful. A lot of the things we do, he actually is a clinician. He steps into the lab, he pushes us, he helps us. Whatever you need, they make sure it's available. And then the Nigerian Institute of Medical Management, they were really, during this COVID era, it was a different thing. That's why I wanted to echo that statement from Professor Altan, where a lot of people put together. I know colleagues that were working on neglected tropical diseases. When we are so overwhelmed, that 2 qPCR machines, we are so overwhelmed. She came in, donated her own real-time PCR system. We could be working with about 3 or 4 real-time PCR systems at the same time to be able to meet up with the demand. And then the ministers of health for Nigeria and the Prime Minister of Health, I really want to appreciate all of them. When we developed the diagnostic kit, they actually organized a situation in Lagos, where in Abuja, where we demonstrated these things. It takes results in about just 5 to 30 minutes. You have your results. I was able to demonstrate that before the committee of the ministers, and then we are looking forward to being able to scale up this to different smaller facilities to work with them. I want to leave you with this as I say thank you. Some of the things we have been doing, they've just been there, and because of the need, we are able to step up. I want to say that the dream is not what you see while you are sleeping, but something that does not let you sleep until we achieve that. Thank you all, and I look forward to taking some of your questions and your comments.